We're going to talk about an important topic here, hemorrhage, interventional radiology, and cell salvage. The title actually includes uterotonics, but for time purposes, I won't be speaking about that. There's just not enough time to include everything. So this is a picture of my hospital. Everyone starts their lectures with a hospital picture, but let's face it, all hospitals look the same. So let's move on. Getting right into this, in 2004, this health alert came out from the state of New York Department of Health regarding prevention of maternal deaths through improved management of hemorrhage. And this was done in response to a number of maternal deaths that occurred in the state of New York, and some recommendations were made. Let's see. There we go. So this resulted in an article being published in the journal Obstetrics and Gynecology. The issue was May 2006, Improving Hospital Systems for the Care of Women with Major Obstetric Hemorrhage. And some of the recommendations that were included in this paper included that ensure that your hospital has guidelines for rapid emergency blood transfusion and coordination among physicians, nurses, and the blood bank. I'll show you some of those guidelines in a few moments, but one of the most important things here is including the blood bank in the process. It's not going to do you any good to have a massive transfusion protocol if your blood bank cannot supply the blood for you. And likewise, just general communication between the physicians that work in obstetrics and those who work in the blood bank is absolutely critical. We have to be totally on the same page and communicating. Be vigilant to blood loss in labor and delivery and early postpartum. Slow blood loss can be life-threatening, and this is sometimes something that we do see in obstetrics, a slow blood loss. Sometimes we're not even aware of how much blood is being lost, but being vigilant to slow, sometimes concealed blood loss is critical. Now, aggressive fluid and blood therapy, if there is large loss, even in the case of apparent maternal hemodynamic stability. And the reason for this is that pregnant patients are generally otherwise young and healthy, have a lot of reserves, can often tolerate a fair degree of blood loss before they'll just crash. So you really need to be aggressive about keeping up in the situation where there's large blood loss so you can maintain stability. Now, this is something very critical. I talked about this in one of my lectures yesterday. Conducting drills. Now, these massive hemorrhages don't happen that often. Some of the other rare events don't happen that often. So it's important that we practice. Practice at a location such as the simulator, or practice even within your own labor and delivery unit. We have drills that we conduct among our own faculty, and that includes not just anesthesia faculty, but obstetricians, nurses, the unit secretaries. Anybody who's involved with this has got to be part of these drills, because sometimes the weakest link is the most important one. For example, recommendations include the continuing medical education, which includes these drills for all labor and delivery staff. And I think this is important. All labor and delivery staff, including people like the unit secretaries who are going to be making the phone calls. It doesn't do any good if the physicians know what they're doing and we ask the person at the telephone to please call for this or call for that, and they have no idea what to call for. So everybody who works in these situations needs to be involved in the drills. Now, with regard to massive transfusion protocols, first of all, your hospital needs one. I'd like to assume that everybody has, is it correct? Everyone has a written massive transfusion protocol? I see a few heads shaking no, okay? So you need one. Now, there are places to get one. So, and I'll show you that in just a moment. So this is just a nice little article that appeared in one of the obstetric journals, obgmanagement.com. You can go to that website. It's a free journal. You can get all the articles there. It's a very nice obstetric journal. If you want to write down that website, obgmanagement.com. But this particular one was from a few years ago. Planning reduces the risk of maternal death, and this tool helps. So here is the tool. Now, if you go to this website, and again, you feel free to write this down, cmqcc.org. That stands for the California Maternal Quality Care Collaborative. You can see that right at the top of the slide there. And if you go to this website, there's a whole variety of resources for lots of different aspects of obstetric care. But if you go to this website specifically and you click here where these arrows are, you see it says, get this pointer up here, OB hemorrhage. And if you click right there, it says obstetric hemorrhage tools. All right, so you go to this website, cmqcc.org. Click right there, and what you'll get is a massive transfusion protocol. Now, you can alter this, of course, for your own hospital if you want, or not. Use it just the way it is. And what you get is something like this. A 4-stage plan. Starts at stage 0, stage 1. 2 and 3 will be on the next slide, which looks at how to assess the patient, certain things that need to be done, various procedures, and how to communicate with the blood bank, what kind of blood products to ask. Basically, it lays out everything right there for you. So you've got stage 0 and 1, stage 2 and 3 here. I'm not going to go through every little point on this slide. You can look it up yourselves and go to the website. But the point is it's all there for you. So for those people who don't have a massive transfusion protocol, you don't have to make one up yourself. It's all there online. You could probably find other things if you Google around, but this is a great resource, and I highly recommend it. So moving on to cell salvage. This is something where some questions need to be asked. One of the questions is it safe? And the other question is it worth doing? We've heard a lot about cell. We had the abstract on cell salvage and the research competition this morning. We've heard some other things about it in other lectures, and you'll definitely be hearing more about it. So, of course, the concern with regard to safety is amniotic fluid contamination. Now, the question, how effective is the cell salvage technology in removing amniotic fluid from processed blood? Well, it seems to be pretty effective. If you look at some of these various products, the modern cell salvage processing is quite effective in removing these products from the blood. There are now hundreds of reports in the literature of the safe use of cell salvage in obstetrics, and of course more are being accumulated every day, such as abstracts we saw this morning or other anecdotal reports. But a couple of things here. First of all, the incidence of amniotic fluid embolism is quite rare, and when you have such rare events, you don't really know how common it is. It's commonly quoted as between 1 in 8 and 80,000, but when you've got a range like that, isn't that just another way of saying we have no idea how common it is? Or rather another way of saying it's really rare, but we don't know exactly how rare. That's what numbers like that mean. But let's get mathematical for a minute. Let's say you have 1,000 cases in the literature of use of a cell saver with no adverse outcomes, and the incidence of amniotic fluid embolism is, let's say, 1 in 80,000. Now, mathematically, you don't have enough, or inadequate power, as we say in statistics. You don't have enough to say that it's safe. So even though we have all these reports of use of cell saver, whether they're published or anecdotal, the fact is that if amniotic fluid embolism is so rare, we still don't really know. The other thing is that although we can measure certain products that the cell salvage technology can remove from the blood, we don't know exactly what it is in amniotic fluid that causes the syndrome that we call amniotic fluid embolism. In fact, it may not even be a sort of quote-unquote embolism of amniotic fluid, but rather some sort of immunologic reaction to something within the fluid. And it's been proposed that maybe we shouldn't call it amniotic fluid embolism, but rather call it anaphylactoid reaction of pregnancy, because it involves some sort of immunologic reaction as opposed to a true embolus. So the reason I'm saying all these things is that we don't really know that the cell saver removes whatever is going to be the problem that causes the syndrome that we call amniotic fluid embolism or anaphylactoid reaction of pregnancy. So moving on, though, some of the logistic obstacles, if you are going to do it, include who's going to set this up and maintain it. Is it going to be the anesthesiologist? Will it be your perfusionist, some other cell salvage resource? Will it be the nurses? Who's going to do it? You've got to establish that. How about getting ready in an emergency? Now, it's one thing if you've got an elective case where a known placenta accreta, for example, elective surgery, and you get all your resources set up. But what about a massive hemorrhage in the middle of the night? Is it going to be ready? Are the personnel going to be available to set it up? How about use in rural, underserved areas? These might be the areas that need it the most, but also have the least resources to actually use this effectively. Now, a question that has recently come up as a controversy is the use of leukocyte depletion filters. Should these be used in obstetric cell salvage? Now, it is standard practice to use these, and most of the recommendations that you will see include the use of these filters, presumably to help filter out what may be some of the products related to amniotic fluid. However, recently there has been a couple of reports. Here's one: severe hypotension related to cell salvage blood transfusion in obstetrics. And this one here, hypotension associated with leukocyte depletion filters following cell salvage. And these are brand new. You see this reference, 2011. The previous one, 2010. So we're talking brand new stuff which is out there. And the theoretic issue here is that the alleged advantage of these filters is removal of particulate cellular matter. However, the disadvantage may be that disruption of white cells may release toxic mediators that might make a problem even worse. So we don't really know if these are the right things to do. Now, I know that most people are using them, but again, we don't really know. Some of these reports of hypotension may be related to the products that are presented as a result of these filters. So with this regard, I would say stay tuned for more information on this, because certainly more information will be coming out as more cases and research is done. Well, so is it safe? I'd say it's probably safe. It's certainly, the evidence out there is suggestive that it's safe, but we don't really know. But yes, it does seem to be safe. Is it worth doing? Well, I'm not sure about that. I'd say it's very situationally dependent. Should we have it set up for every cesarean section? I don't think so. Certain selective ones, probably, but this will also depend on the patient's wishes. For example, some patients wish to preserve their uterus. Others are fine if the case results in a hysterectomy. If the patient is one who is okay with having a hysterectomy and massive hemorrhage is encountered, the obstetrician will clamp the appropriate vessels and ligaments and take out the uterus. And hopefully things will get better. Maybe the ones that want to preserve the uterus are more likely to require large transfusions. So let's just move on. So anyway, it's still very much an open question. So the next topic that we'll talk about is interventional radiology. And this is something which is really emerging as an important adjunct to our obstetric anesthesia care. I'm just curious, by a show of hands again, how many people have facilities for interventional radiology in your hospital? See, just a small number of hands, a couple of hands go up. So you will be seeing it more. And here's just an example from a newspaper in the United States, OBGYN News. You see IR, interventional radiology, obstetric team targets bleeding. By the way, that's me in the picture there. So in obstetric newspapers, and it's certainly being talked about quite a bit within obstetric resources. So, of course, embolization therapy can be used for a whole variety of things. This includes gastrointestinal bleeding, pelvic fractures, trauma, after post-operative issues of regardless of what type of surgery in oncology. But of course, what we're talking about here is pregnancy and uterine artery embolization. So antepartum, this can be used prophylactically. We'll sometimes place these balloons and catheters prophylactically in certain selective cases. Postpartum, it can be used therapeutically in the case of bleeding. So some of the reasons why you might use interventional radiology include lacerations of the birth canal, abnormal placentation, retained products of conception, uterine atony, or uterine rupture, among others. So I think we're all pretty familiar with some of these pictures. These are just different placental abnormalities, accreta, increta, and percreta. And we can see what they look like radiographically, basically the difference being how deep into the uterine muscle the placenta has invaded. And I'm not going to go through all the different pictures here, but percreta obviously being the worst, where the placenta actually goes through the uterus and into abdominal contents, into other organs, most commonly the bladder, but can be involved with virtually any other organ in the abdomen. So now this article appeared in the International Journal of Obstetric Anesthesia a couple years ago, titled Selective Arterial Embolization, a First-Line Measure for Obstetric Hemorrhage. And this asked the provocative question, should we be doing this early? Now, certainly in my institution, and I'm guessing in most other institutions that use this, it has traditionally been a last resort. You try everything else first. A few hands went up in the front. Isn't that correct? You try everything else first, then when all else fails, well, let's get the radiologist involved. Well, maybe the right thing to do is getting radiology involved earlier, before really the patient is in extremis. So that's really what this article was proposing. Remember, this has a very high success rate. There are actually relatively few complications. There are a few, and I'll go over those, but it's a relatively safe procedure. Surgery is always available if needed, if the radiology procedure is not effective. And surgery first could make later embolization difficult or impossible. So there are lots of reasons to use an early radiologic intervention. The technique, don't have to go through all the details in great depth, but basically access to the vascular system is obtained usually through the femoral arteries. Pelvic arteriogram is done to identify where you are, and then the selective radiography is done to determine the various vessels, and then embolization occurs based on whatever particular vessels need. So early and rapid intervention, quickly and safely performed with gel foam patches or slurry, some pictures of the embolization material that can be used. Balloons are often used as well, so various embolizing materials or the balloons or both. And it's just, you don't need to be a radiologist to show that there's less blood flow here than here. So it's actually quite effective at this purpose. Same thing, you can really cut down on pelvic blood flow with these procedures. Oh, I don't see Dr. Kadali here, but I just put up Dr. Kadali since his nice smiling face always brings a smile to everybody else. So, but he wrote this article, Bhavani Kadali, and my colleague at Brigham, and just published recently last year in the International Journal of Obstetric Anesthesia, Bloodless Trilogy, Anesthesia, Obstetrics, and Interventional Radiology for Cesarean Delivery. And basically the point of this article was that we all need to work as a team, and that team needs to include the radiologist. So we are so used to, as anesthesiologists, working in close conjunction with obstetricians, but in this particular instance, the radiologist can really offer us a lot of resources. So with regard to complications, they're generally unusual, and they're typically complications of the angiography itself, such as needle puncture trauma, pelvic infection, or ischemic phenomena. Now, some of the controversies include, do people who have had pelvic arterial embolization have subsequent problems with fertility? And the answer seems to be no. There's pretty large number of patients that have had these procedures and then have effectively gone on to have subsequent pregnancies. So it does not seem to cause fertility or subsequent problems with future pregnancies. So it is relatively safe. Now, these are some other important logistic issues. Qualification of the team. We all know as anesthesiologists, some of us are better than others at doing the various things that we do. Same thing with radiologists. Some are better than others. The flexibility with regard to the timing is important. Specifically, some places, it's only available during the daytime. Other places, it's available at nighttime as well. So you need to know what your radiologist's schedule is to determine when these things may be available. Now, the interventional radiology suites are often a far distance from the operating room suites. So are you going to have anesthesia equipment or the ability to provide anesthetics in the radiology department? These are one of the practical issues that needs to be settled. And if you do, who's going to go there? If you have someone covering labor and delivery, is that anesthesiologist going to be able to go to radiology in the other part of the hospital? Who's going to cover these things? So these are other practical logistic issues that need to be settled. Now, some other practical points. If you're going to do this prophylactically, in other words, put balloons or catheters in before a cesarean section, then what you want to do is do the epidural before you do the radiology procedures. And the reason is once the patient has catheters in the femoral arteries, it's quite difficult, if not impossible, to position them in the proper position to do an epidural. So get the epidural in first, then place the balloon catheters. The logistic issue with postpartum is that you may need anesthesia personnel to accompany the patient to the interventional radiology suite. So these all need to be worked out. Now, I'll conclude with just a few comments about something we've done at my hospital, which is quite a unique. Ooh, I'm getting the buzzer here. I've got about 1 minute to go, maybe two. Where we've done cesarean delivery, elective cesarean deliveries, actually in the radiology suite. Typically what's done is the balloons are placed and you go back to the operating room and do your cesarean section. But we have done a number of procedures electively in the radiology suite. This was reported in this article now back in 2007. Since then we've done many more cases. But cesarean delivery in the interventional radiology suite, a novel approach to obstetric hemostasis. Elective cases, the entire procedure was performed in radiology, the advantage being that you have improved visualization to manipulate these catheters compared to some of the portable radiology equipment that we could bring back to the operating room. Now this is just a couple pictures that I took during some of these procedures, and what's unique about this is something that you don't see very often. Here's a couple of, actually one of our nurses and one of our obstetricians. So they've got those lead aprons that we use to protect ourselves from the radiation, and there's a fetal monitor. How often do you see a fetal monitor and radiology aprons in the same room together? Okay, that's just a picture of the scene of the operating room. And here's one of our obstetricians with the newly delivered baby. But if you look carefully, there's the C-arm, the radiology C-arm. How often do you see a brand new delivered baby right next to the radiology C-arm? So in conclusion, this is a very useful technique. We need to be involved in all aspects of planning these procedures, and there are many logistical obstacles that need to be worked out unique to your particular hospital. And with that, I'll conclude, and I thank you very much for your attention.